Okay, ladies and gentlemen, we're going to get started. Esteemed guests, distinguished speakers, a warm and heartfelt welcome to the inaugural Heart Attack Detection Summit. I'm Holly Windler, one of your hosts for this session. Today, we embark on a journey to explore a revolutionary advancement in healthcare, highlighted by the pioneering Guardian system, the world's first and only FDA-approved real-time heart attack detection and patient alerting system. This groundbreaking innovation not only promises to enhance the long-term care and outcomes of high-risk patients who have survived prior ACS events, including heart attacks, but also stands as a beacon of hope for clinical practice, offering real-time alerts for the onset of ST shift, as well as abnormal heart rates and rhythms. Heart attack prevention is transformative care because preserving muscle is preserving long-term health. And with over 9 million heart attack survivors and 800,000 new heart attacks every year in the United States, let us unite to explore the Guardian system's potential to transform the well-being of those we serve. Welcome to the first Heart Attack Detection Summit. Today, our agenda is focused on listening to experts who have successfully integrated Guardian into their medical practices and witnessed benefits for their patients. Each presentation is designed to be a concise 7 or 8 minutes-ish, followed by a panel Q&A session. We're on a mission here at Avertix. Our mission is to unite families. And after all, our goal is to keep families together. Our first speaker isn't with us today, but he means a lot to us, and his story does as well. You see, Robert was a very active man that lived every day in pain, yet still persevered to live his life to the fullest. The one thing that held him back, however, was fear. He was tethered to live a life within a certain distance of an emergency room. Let's hear directly from our patient, Robert, about the impact the Guardian has had on his life.
You know, I really have a peace of mind because I know it works now. And the 3 times it went off, I didn't have a heart attack, but I was getting ready to. So I know I got some time. The first time it went off, I was at the grocery store, and my girlfriend and I kid around a lot. I mean, I just kid around a lot. And we were shopping, and she was in front of me, and started vibrating. I said, "Cindy, it's vibrating." She goes, "Robert, no, it's not." And I took her hand, I put it on it, and she panicked. Thank God I listened to it, because I was about to have a big old heart attack. Seriously, if I didn't have the Guardian, I wouldn't be here. And that's all there is to it. I would not be here. It works. It works. You know.
Wow, that was powerful. Thank you, Robert. Wish you were here to hear that. I'm happy to introduce our panel of distinguished speakers who are experts in the field. This group has prepared for you presentations based on research or their clinical and facility experience. Furthermore, as stated, the Avertix team is here to support in managing the chat. And we are happy to have folks such as our CTO, Dave Keenan, with us, as well as the CEO of Pinnacle Health Group, Kathy Francisco. Please join me in extending a warm welcome to our panel. Say hi, panel.
Hi, everyone. We're glad you could join us today.
Hello.
Now, allow me to introduce our CEO, Tim Moran. He's an accomplished leader with over 25 years executive experience in the medical device industry. And prior to joining Avertix, Tim served as CEO of Modus GI and held various leadership roles at Covidien for nearly 2 decades. Following Medtronic's acquisition of Covidien, Tim assumed the role of Global VP and GM of Patient Care and Safety, overseeing a division with annual revenues exceeding $1 billion. Tim, the stage is yours.
Great. Thank you, Holly. And let me start by just extending my appreciation to everyone on the call tonight who has been willing to invest time to learn more about Avertix and what we're setting out to do in the marketplace. We're dedicated to innovating cardiovascular disease management through our Guardian system, which is designed to both save lives and keep families together. Before we hear presentations from our panelists, I want to provide just a quick overview of our technology to level set, talk a little bit about the functionality, the patients that we're serving with this device, and some of the clinical outcomes. Here you'll see the Guardian system in action. So as we discussed, this is the world's first and only FDA-approved heart attack detection and warning system. And when the company was founded, we set out to be able to save lives and the impact that heart attack have both on the patient, but also on their family. We all know that heart attacks are prevalent. And we have a very broad indication for Guardian that we received from the FDA, basically requiring a patient that has had one prior ACS event, and they are eligible to receive the Guardian system. We've seen the statistics, and we know that if someone's had one MI, the potential to have another goes way up. Every 40 seconds, somewhere in the United States, someone is experiencing and suffering from a heart attack. And there are more than 800,000 heart attacks that occur each and every year. And we know, and you listen to the video from Robert, we know the fear and anxiety that is then set upon that patient after experiencing this event. And we believe that we can help these patients together in partnership with each and every one of you on the call tonight. In addition to recognizing a typical heart attack, what's really innovative about the Guardian device is we also can detect atypical or silent events, which we know, and statistics will show, can be upwards of 50% of the attacks that occur. We also know that there's significant prevalence in women. 4 out of 10 women will experience a heart attack that wouldn't have the typical symptoms of crushing chest pain, and 3 out of 10 men. We conducted, as you would imagine, a large randomized control trial in support of our FDA approval. During that trial, one of the more notable outcomes really showed what we set out to do. We reduced the time from the onset of a heart attack occurring to getting the patient to the emergency room by almost 8 times. So from almost 13 hours in the control group that didn't have the benefit of Guardian to 1.6 hours for patients that had the Guardian with the alerting. This was really compelling. And also during this trial, we detected 42 silent MIs. If you look at the entire enrollment population, more than 50% of the patients that had Guardian during our trial got to the emergency room where they could get intervention in less than 2 hours. This is significant as we know that time is muscle. And we're really looking to reduce the impact to the patient's ejection fraction. So in addition to ST segment monitoring and heart attack detection, the Guardian also can pick up other cardiac complications and arrhythmias. You see some of them listed here, atrial fibrillation, for example, or atrial flutter. When the system detects an arrhythmia, what it'll do is it'll provide an alert to the patient, similar to what you saw in the beginning where there was the emergency alarm, but we have what is called a see doctor alert. So these are for other complications, so they can notify the patient that they then need to reach out to the physician to schedule a discussion and ultimately an appointment. And finally, as I mentioned, we do have clearly our FDA approval, but the device is also reimbursed from the Centers for Medicare and Medicaid Services through the transitional pass-through payment. So what I'd like to do, you're going to hear some terrific information tonight, but we put together this little checklist on the side and basically talking about patients that have had one prior ACS event and also may have some other comorbidities that put them at higher risk, such as being a diabetic or obesity or a smoker. My challenge to the group on the call as healthcare providers is I'm sure you're already thinking about patients that you know can benefit from the Guardian system. And what I would ask is allow us to be your partner in bringing this technology both to your practice, but also to patients in need. So thank you very much. And again, I appreciate everybody's joining the call tonight. And Holly, I'll turn it back to you.
Now that we've had the appetizer, let's get to the main course. I'd like to introduce our Dr. Kaplan, who will serve as our moderator for today's event. Dr. Kaplan earned his medical degree at the University of Texas Southwestern, followed by internal medicine training at Duke University. His expertise extends to cardiology and electrophysiology gained through training at Emory University. Based in Phoenix metropolitan area, he currently serves as the Director of Electrophysiology at Phoenix Heart, Vein, and Vascular. Dr. Kaplan's extensive involvement in clinical research spans over 75 trials, with roles as both clinical and principal investigator. He currently serves on the Verdict's Medical Advisory Board. Dr. Kaplan, the mic and the stage are yours.
Thank you, Holly. It's wonderful to be here and wonderful to have such a large audience joining us this evening. My journey with the Guardian has been long. I was a clinical investigator for the Alerts trial and have been able to follow it from a research standpoint through its commercial development and getting it out to my patients. And so it gives me great pleasure to join you this evening. What I'd like to do is present the results of a study that I recently presented at the TCT conference in San Francisco entitled Medication Adjustments Associated with Implantation of a Cardiac Alerting Device, the Alerts Trial. So as you've already heard, the Guardian is the world's first and only implantable system designed to detect acute ischemic events related to coronary artery occlusion. Alarms prompt patients to seek medical attention. Alerts was the pivotal trial evaluating the efficacy and safety of the Guardian system. The primary endpoint was positive for improved recognition of acute ischemic events compared to symptoms alone, and for reduction in symptom to hospitalization presentation time. As part of the study, data on the use and adjustment of medications was collected. This was felt to be important because ACS patients remain at high risk for adverse outcomes after initial treatment. The high-risk ACS patients all had to have experienced an ACS event within 6 months or had undergone or had planned to undergo coronary bypass surgery within the next 6 months. The major exclusions were presence of a clinically significant arrhythmia, which could either reduce accuracy of the device to detect ST segment changes or could lead to the need for an implantable CRM device. Randomization took place at the first post-implant visit. All patients who were enrolled in the trial did receive a device implant, which is very similar to a pacemaker insertion. Most of these were done as outpatients. The follow-ups were scheduled according to physician preference as well as per protocol. Additional visits could be unscheduled, related to either changes in symptoms or for device alarms. At 6 months in the study, there was a crossover with alarms turned on for the control group. The active alarm group continued to have alarms on, and both groups were followed for the remainder of the trial. As you can see, for the emergency alarm, the patient was told to go to the ER for evaluation. And then for the C-doctor alerts, they were told to contact their physician and to come into the office to have the device interrogated. Patient notifications can be broadly broken down as to whether they were ischemia related or rate and rhythm related. For ischemia, the emergency alarm would constitute an ST segment shift in the absence of a change in heart rate, or if there was ST segment change associated with persistently elevated heart rate. On the other hand, for the C-doctor, there was a negative ST segment shift, otherwise known as a recovery event, in which there was ST segment changes just after a recent interval of higher heart rate, or if there were ST shifts associated with elevation in heart rate lasting for more than 10 minutes, constituting demand ischemia. This is essentially the equivalent of a stress test. In terms of the heart rate and rhythms, alarms could occur for either high or low heart rates, as you can see here for the specific indications. And they also could occur in instances of an irregular heart rate. This is an example of some of the data that's available. Device interrogation will show the reason for the alert, as you can see in the lower left corner, with this example occurring because of a high heart rate. Additionally, there are pictures of the electrograms that are captured by the device at baseline as well as hourly, and then within minutes before and during the event. Additionally, as you can see, there's 6 months of heart rate histograms that are available for review in the lower right corner there of the slide on the left. The primary endpoints were assessed for 907 subjects who were broadly broken out, and data for medication usage adjustment was also collected as mentioned previously. Medications were classified into 4 specific groups. The first were the class 1 and 3 antiarrhythmic medications. Group 2 were class 0, 2, and 4 antiarrhythmics. Group 3 constituted antiplatelet and anticoagulant drugs. And then group 4 were non-cardiac related as well as hypertension medications. The potential reasons for adjustment could be through a standard of care visit, through visits due to symptoms, or for the scheduled visits that occurred at 1 month, 3 months, 6 months, and then every 6 months thereafter, which would constitute a visit along with review of the intracardiac data. Patients could also have their data evaluated due to C-doctor alarms or emergency alarms. The ALERT study did not survey doctors on the rationale for medication titration, but the only differences between the 2 cohorts would be the availability of intracardiac data and then the various C-doctor and emergency alerts. This is a breakdown of the types of alerts that were occurring for the C-doctor alert type. The majority of the alerts were related to abnormal heart rhythms across the groups in the alarms on, crossover, and then continued alarms on, with a fairly even breakdown of whether they had a high heart rate or an irregular heart rate. There was also a smaller but still significant number of non-acute ischemic events documented. All of these alerts could lead to medication titration. These are the results of the study. The number of patients with medication titration was 220% higher in the alarms on group compared to alarms off for group 2 medications, as seen in the upper left portion of the slide. This was highly statistically significant by chi-square analysis. There were no significant differences for other medication groups. The total number of medication titrations seen in the lower left was 162% higher in the same group with alarms on. There was an equal number of new scripts as there were for dosage adjustments in previously prescribed medications. An increase was also observed for the crossover group of 25% compared to the existing alarms on group, again, strictly for group 2 medications. This was a positive trend, but did not reach statistical significance. You can see there was also a catch-up. This was believed to be a catch-up for the group that now had data available for the clinicians. This is an example of a detection related to high and irregular heart rate, in which you can see that the patient has atrial fibrillation. The benefits of an intracardiac electrogram are that you can clearly see both atrial activity as well as ventricular signals, and we can get a handle on the heart rate control with these events. These are 2 more examples on the left, being somebody who had a high burden of ventricular ectopy with ventricular trigeminy documented. And then on the right, an example of supraventricular tachycardia. Both of these could lead to medication adjustments and/or electrophysiologic intervention. The conclusions that arose from this study were, number 1, that high-risk ACS patients remain at risk for recurrent ischemic and dysrhythmic events related to their underlying substrate as well as progressive disease. The presence of an ischemia monitoring device with additional heart rate and rhythm diagnostics led to significant differences in the use of group 2 medications, that is, beta blockers, calcium channel blockers, and ivermectin, reflecting enhanced patient management. This may have contributed to positive outcomes from the trial. Likewise, it may prove to enhance long-term outcomes in these high-risk patients. This will be evaluated in future research. Thank you for your attention, and I look forward to answering any questions at the end of the presentations during our panel discussion. It is now my pleasure to introduce Dr. Claudio Manubens, Chief of Cardiology, Advent Health of Florida in Davenport, Florida. He is going to share his expertise on Guardian patient selection. Dr. Manubins, the stage is yours.
Thank you, Dr. Kaplan. I hope everybody can hear me. And hello, everyone. I'm just going to take more of a personal approach of my own experience after I've embraced this technology. As chief of cardiology, we review STEMIs every month, and average of 10 to 15. And something that has really boggled my mind is the number of young patients actually that are coming into the emergency room with acute coronary syndrome. You know, back in the day, it used to be in the 70s, 80s. Now I'm seeing patients in their 50s and 60s, young patients coming with acute coronary syndrome. And obviously, sometimes the outcome is not good, especially when you're do a little bit of research and find that some of these patients are not showing up from 12 to 16 hours after the initial event. And as someone already mentioned, time certainly is muscle. And, you know, we do a very good job in the emergency department to make sure that we get that EKG within 10 minutes and, you know, door to balloon within 90 minutes. But it doesn't do us any good if we are not getting these patients to come into the emergency room. So I embrace this technology because I know that we're in a time where, you know, we have AI, we have also, you know, great technology. I know my car is always reminding me to pull over and have a cup of coffee when I'm driving erratically because I'm answering calls or texting or whatever. So why not offer this technology to our own patients? And I've embraced this for the last probably 9 months or so. And I found that most patients actually that are in this situation, we know that AFib begets AFib and stroke begets stroke. Certainly acute coronary syndrome is something that we can't just ignore it, you know. And I used to tell my patients, you can't predict myocardial infarction, you can't predict an earthquake, but now we know that that's no longer the case. So if we have this technology, why not use it? So we know that some of our patients present with some atypical symptoms. You know, we had a patient last week where actually presented with epigastric abdominal pain, was getting a KUB, CT of the abdomen and pelvis, and the emergency room doctor said, well, I did an EKG just because the patient was 70 years of age. And lo and behold, you know, ST elevations, inferior leads, patient went to the cath lab immediately, had 100% right coronary artery. So we have to look for patients that may be diabetic, smoker, multivessel disease. We know females present with typical symptoms, underrepresented minorities, atypical chest pain, as you can see in the list. So we always want to be alerted and kind of be proactive, ideally. That's what I tell my patients, rather than be reactive at 2 in the morning, I'll call 911. I'd like to just present a couple of studies. You know, some of my patients, the one on the right, for instance, a 62-year female, an avid golfer who, you know, had some silent event, no symptoms, but after having distal left main and 99% occlusion of the osteo-LAD, went for LIMA to the LAD, her activity was very much curtailed. She suffered a typical depression post-MI. And, you know, I talked to her frankly and candidly about this technology, and she embraced it right away. And after that, I think, as it was shown in the patient testimony, my patient now feels much better. She's able to play golf. She's active. She's not worried about the next event, you know, so she can live at peace. And I think that's a wonderful, wonderful way that we can improve the quality of life. We're all about quantity of life, but here in this case, I think we're doing both. And the second patient I want to talk about is a young male that I had done a cath and actually only had about 30% stenosis, a minimal plaque. I said, everything is fine, don't worry about it. And a week later, his wife calls me and says, well, he's having chest pain. I think he needs to go to the emergency room. And he said, no. Doctor just said everything was fine. Well, lo and behold, I told him to go to the emergency room. Sure enough, he was having acute coronary syndrome. But in his mind, there was really no reason for him to go to the emergency room. So I think spousal stress relief with Guardian is obviously very, very important. And the third case I'm going to present, I'm sorry, it's not in the slide, actually happens to be my brother-in-law, and I like my brother-in-law. And, you know, 52 years old, diabetic, no symptoms whatsoever. Finally, I convinced him to get his cath done. Certainly had 100% right coronary artery with left right collateral, so something that happened probably a while ago. His LAD was 90% proximal, circ was 80%. Decreased left ventricular systolic function. I'm talking to him about bypass surgery. He's like, well, let me check my schedule, maybe 2 weeks from now. I said, no, we're going right now. We're going right now for cabbage. And he also became another candidate for this device. And now he feels much more at ease, and certainly my wife is much happier than for this case. So for me, any patient, as Dr. Kaplan described, any patient with acute coronary syndrome who's had higher risk, anybody who fits that criteria, what I do is I just talk to them. I said, listen, we do have this device. I want you to learn a little bit more about it. And I'm going to schedule you to come back next week. And one of our reps, Matt is in my case, will come to the office. We'll show you a slide. We'll show you a film. And then you can discuss it. You can discuss it with him, look at the pros and look at the benefit, look at the risks, and then make a decision. And right now, I would say about 80% of the patients that I discussed, they've been very much willing to go through the procedure. I asked one of my EP guys to do it. I could do it myself, obviously, but I'd rather just let somebody else do it and who has great expertise. But certainly any cardiologist who feels comfortable doing pacemakers shouldn't have any problem doing it. And not only it's a great sign of making sure that everything is fine with acute coronary syndrome warning, but also, as was already stated, I've been finding myself doing a lot of medication titration to improve quality of life, whether it be tachybrady syndrome. And, we all know that a 24-hour Holter monitor is kind of worthless, right? We say everything is fine. We don't really know what we're looking at. So I think this gives us great relief in improving patients' quality and quantity of life as well. So I'll stop right here, and I'll be glad to answer any questions from my personal experience. Thank you so much.
Thank you, Dr. Manubins, for your enlightening insights. Great cases. Again, please post questions for Dr. Manubins in the chat, and we will get to them in the Q&A. Next, we have Dr. Hirsch Naik, who is the Chief of Cardiology and Director of Structural Heart Interventions at Dignity Health St. Joseph's Hospital and Medical Center in Phoenix, Arizona, where he holds a clinical professor position at Creighton University School of Medicine. He completed his medical and cardiology training at Albert Einstein College of Medicine, as well as an advanced interventional and structural fellowship at Cedars-Sinai Medical Center in 2010. His expertise encompasses structural heart disease and complex percutaneous coronary interventions using cutting-edge mechanical support technologies. Dr. Naik is a clinical investigator in international multi-center clinical trials, co-authoring numerous peer-reviewed scientific articles. Additionally, he serves as a national and international clinical proctor for transcatheter valve implantation and repair, offering advanced training courses in both coronary and structural heart therapy. Dr. Naik will discuss diagnostic management and continuous monitoring post-complex PCI. Dr. Naik, the stage is yours.
Thank you, Dr. Kaplan. That was a kind introduction. I appreciate that. So we're a big high-risk complex PCI center. And so what that means is ejection fraction is very important to us. That's what we're trying to improve. That correlates very well with patient outcomes, obviously. So we think that there's a big population that's not very well treated, mainly surgical turndown patients. And with the advent of new technology and better systems to use, we're able to treat these patients. So what I'm going to do is show a typical case that we offer Guardian to, a typical patient. It's a complex PCI patient. This is a 63-year-old. He had diabetes, hypertension, and COPD. He presents with shortness of breath and angina on exertion. 2 years ago, he had an LAD drug-eluting stent. His circumflex at that time was described as 100% occluded, and his RCA had some moderate disease. 6 days later, had stent thrombosis that led to a second stent proximally. Currently, his creatinine was 1.9. His ejection fraction was 25%. So at 25%, he's not a Guardian candidate for us yet, but he does deserve complex PCI. As you can see here, he has a chronic total occlusion of his circumflex artery. His left main LAD has issues and an EF of 25%. So he was a surgical turndown. This is what's important. These patients are now being treated. So this is what I want to kind of illustrate is that before, these patients were going to either medical therapy because they're surgical turndowns and not living that long, or really just going to hospice automatically. And so we're treating them now. So his plan was the plan after discussion with our whole complex PCI team, which includes surgery, a heart failure cardiologist, and myself, an interventional cardiologist. We decided to proceed with high-risk PCI. and with Impella CP support, percutaneous mechanical circulatory support. And our goal was to treat the CTO of the circ, his LAD, and left main. So go ahead next. And that's what we did. We opened up his circumflex artery, and we used the shock wave based on IVUS, which is another tool that helps us achieve complete revascularization, which improves EF. And so we fixed the circumflex artery. You can go to the next slide. But we also fixed the left main and LAD with another stent, and he did well. Actually, post-op, his 90-day follow-up, his ejection was 40 to 45%. So what that means now is we've done all this work to get his EF to 40 to 45%. All this PCI, and like Dr. Kaplan said, ACS patients, as he's shown in the LERS trial, they have a higher risk of having further events, obviously. And so we don't want to go backwards, especially the hospitals don't want you to go backwards because a lower EF means more heart failure hospitalizations. But us as cardiologists don't want our patients to go backwards because of a low EF. So this is the key. The preservation of ejection fraction or improving ejection fraction is king. That's the king to hospitals. That's the king to us. I think all of us on the call are cardiologists, but everything, I have a different discipline. EP has a different discipline. Heart failure cardiologists have different discipline, but it all centers about heart failure. So heart failure can go to complex PCI, can get a bi-VA ICD, and now I think an ejection fraction more than 35% ACS patients, they can get a Guardian too, because what are we trying to do? We're trying to make sure that the ejection fraction doesn't worsen and we preserve the ejection fraction. So I think it's very important in patients like these, especially since they could be having silent MIs and worsening MIs that lead to a decrease in EF without us even realizing it. And again, spending all that time, equipment, cost to get them out of hospital improving EF, I think these patients deserve a Guardian, so to speak. So that also it helps with it impacts our time to door for heart attacks. Time is muscle, like what was already mentioned. If you have if your chest pain to procedure is less than 2 hours, you're not going to lower your EF. If it's more than 12 hours, then yes, they're going to have some EF issues, ejection fraction issues. Early arrhythmia detection is important, but again, in the end, you can read it yourself, but it's like having, we used to say when we use the Impella percutaneous mechanical circulatory support in high-risk PCI, it's like having a seatbelt. You don't need it every time, but when you need it, you really need it. And so it's the same thing with the Guardian. I think you're not going to need it all the time, but when you need it, you're really going to need it because then, you're saving the patient's EF. So that's kind of where, this is just an example this is a typical patient of ours with complex PCI, and we're starting to feel more and more comfortable offering Guardian to patients like this overall for our heart failure program. So thank you.
Thank you, Dr. Naik. I think you hit on some very important points, especially showing how once you've put in the work to salvage muscle, you want to make sure that you don't have another event and lose all of that progress. Again, please post questions for Dr. Naik in the chat for our panel Q&A. Moving on, we have Erica Albritton, who is the Vice President of Operations at HCA Florida Oak Hill Hospital in Brooksville, Florida. She will discuss how her hospital system successfully integrated the Guardian technology and program through a billing and reimbursement overview. Erica, welcome.
Hey, thanks for having me. All right, let's go to the first slide. And so one thing we're going to cover is really how we set up the structure around this new technology so that we could be successful with patient outcomes and financial outcomes as well. And that's very important when bringing in a new technology into a service line and hospital. So our physician champion came to us and said, I want to be the first in North Texas. I was in Texas at the time when we did this, to implant this novel device with artificial intelligence and everything that it can do for his patients. So that was the pillar that we built around from there. I was in the director position at the time and was the administrative leadership champion. And my role was really to ensure that obviously our cath lab staff was trained and appropriately understood what we were doing, made sure that our billing revenue integrity department had all of the tools they needed in order to bill appropriately, and kind of connected the Verdict's local team, Tom and his team, to help us all pull everything together between the physician office and the hospital. And without the Avertix local team, we would not have been able to do that successfully. We really got ahead of the billing and issues with this new device by having open meetings with our revenue integrity department, but also with the Pinnacle Health Group. And so I'm going to explain more what the Pinnacle Health Group did for our reimbursement. So this Avertix support with the Pinnacle Health Group was integral. It really, on the front end, ensured that we had patient authorization before we scheduled these patients. And so how we did that is Tom, the local Avertix representative for us, he partnered with the physician office, and that's going to be really important as you integrate this into your system. He partnered with them, came in on a weekly basis, and began the patient funnel. He partnered with the PA of our physician champion. She would take the iPad, show the videos of the Guardian system to the patients who qualified. And if they were interested, Tom would then help them get the patient into the Pinnacle Health Group portal. And then they would start the process. Once they had their authorization, we would get them on the schedule at the hospital. So that was the front end part of the billing. And we did not have a single issue with the cases that we did on getting reimbursement once they had that pre-authorization. We had one managed Medicare that was our very first patient we did. They even helped us on the back end when we had one question on the billing because our physician decided he wanted to admit that patient for obs overnight, and Medicare wanted us to have it as an inpatient. And so they came through, Pinnacle saw the patient the whole way through and ensured that account closed out and was paid. And so that was very helpful. And again, between Pinnacle and the Avertix local representative we ensured that was successful. And so the resources that they provide are very important in being successful here. Extensive in-services for all of our departments, from the ER, the cath lab, and our pre and post-op unit, as well as working with our revenue integrity departments, providing the implant support. They show up the day of. They do bring yummy food for our team so that they can have breakfast in the morning, and you know how the cath lab loves to eat. And they provide the implant support as well as the follow-up support. So if those devices are alarming, I never heard one time that they had to wait for the Avertix team to show up to the office to help with the patient. So here are the reimbursement codes that we were successful with the pool of patients we kind of trialed at first. We used the hospital-specific APC payment of 0525T and the transitional pass-through payment for C1833. And again, we did not have a single issue other than that one little Medicare. We just had to make sure the patient was on inpatient status when we admitted them. And then this will kind of show you the commercial payers were really good and they were very consistent. We had a little bit of a mixture of, we had Blue Cross Blue Shield. I want to say we had a Cigna and maybe another one, but for sure Blue Cross and Blue Shield was one of our main ones that we had. And you can see that they did a payment of $72,908, and we had a contribution margin of $62,800 there for the hospital. The Medicare paid out much like a pacemaker. It was about a $16,000 payment when we had a contribution margin of about $6,000 there. So about the same as a pacemaker that we usually see. It's very important, I think, that when you're setting these programs up you're just kind of paying attention to that payer mix so that you can ensure, the patient outcomes, as you heard the physicians before me speak, they really speak for themselves, and we really saw that. So that wasn't a concern once we got into this, but really ensuring that we're not taking a hit on the financial impact for the hospital and for the physicians was important. So making sure you're paying attention to that as you kind of start the program up, I think that was very vital to our success, because I've been gone now for about 3 months and the program has been going for about 1.5 years since we did our first Guardian, still doing very successful work over there. So this is not my this is not my expertise at all. However, we need to mention this. The physicians receive the professional fee reimbursement. So it's very important to partner with your Avertix support system, support locally, to ensure that you guys are getting the reimbursement that you can on the physician follow-up visits, as well as on your implants. You can see here on the slide that you get paid for those follow-up visits. And so partner with your local team to ensure that you're billing appropriately with these CPT codes and getting paid to do the great care that you're doing.
Thanks, Erica. That's a really great overview. I know that just having something that's FDA approved does not mean we can get it in our hands to help our patients. And there's a lot of work that has to go into meeting with value committees and setting up to show the financial aspects of this, but it certainly is beneficial to the hospitals. I'll also add personally from the perspective of someone who implants in an ambulatory surgery center setting that we generally receive reimbursement at about 60% of what the hospitals receive, and we are doing well with that. But thank you. We will now proceed with the panel Q&A session. Our team has been monitoring the chat and will read questions from there for our panel to address. Holly and Mike, do we have any questions?
I have one that was texted to me. So, Dr. Kaplan, could you walk the group through your follow-up care? How often you bring the patient in if there's not an alarm? Kind of just walk through that in your practice, if you could be so kind.
Absolutely. So in general, I share these patients with my interventional or general cardiology colleagues. So from the standpoint of an electrophysiologist, I'm monitoring the device function as well as data that pertains to arrhythmia. So if there are any heart rhythm alarms, as I outlined, then I will address those. The other physicians within the group like to have the devices interrogated quarterly, for which there are codes and reimbursement available, so that they can review the diagnostic information as well, looking to see things like the average heart rates and whether there were any subclinical ischemic type events. And of course, if the patients do have any alarms, then they address those either in the hospital or in the outpatient setting if it's a C-doctor alert. Dr. Manubins or Dr. Naik, do you have any response to that as well?
Manubins, I have a similar experience, Dr. Kaplan. I work closely with with Matt, who's my guardian rep, and we were in constant communication. If there's any issue, especially where it's medication adjustments or anything like that, we just have the patient come into the office. Other than that, we do quarterly monitoring. So it's pretty much the same thing.
Yeah, so I'm as an interventionist, I kind of remove myself from the situation because you guys are better able to handle it, I think. But so I have an EP physician that implants. I mention it to the patient afterwards. Hey, you've gone through a lot with your complex PCI. We're getting your ejection fraction up, like I mentioned, and we have something that can monitor that. They agree. The EP physician places it in, and then I have that team kind of follow up with them afterwards. That includes a heart failure physician as well.
One thing that I can add is also we need to educate our emergency department, because some of my patients show up to the emergency room and initially they had no idea what the Guardian meant, but now we've been educating our local emergency department about what the Guardian is all about and giving some lectures so that way everybody knows what to look for.
There is a question that about remote monitoring or the plan to do that. So, Dr. Kaplan.
Absolutely. The next generation of the Guardian will have remote monitoring capabilities. We know that that's a class 1 recommendation from Heart Rhythm Society, and there's active work going on to create that sort of system where eventually the device will be able to communicate directly to physicians via their phones, probably, so that they'll be able to look at those electrograms in real time and decide on whether they need to activate the lab. So we're looking forward to that development in the near future.
And this is for the group. There's an interventional cardiologist that's very interested in it for one of his patients. And the question is, how does he sell it to his patient? What's the best talk track that the three of you may have encountered?
My experience is just to have a very candid conversation with your patients and say, look, I mean, there's such thing as silent ischemia and silent acute coronary syndrome. And, we may have no warnings prior to this technology, but now we do. And I think, yes, there's risks involved, but very minimal risks, and the benefits far outweigh the risks. And let's show you a film, become educated, and then you can make a decision. Like I said before, 80% of my patients are more than willing to say, yes, I want to have it done. So I think just a candid conversation with them is the answer to the question.
I've got looks like I got a question here for the panel. Would you prescribe the Guardian for a patient that was a prior ACS event, had a 25% lesion that is diabetic, or had a previous silent or asymptomatic event? Leave that up to three of you guys to answer.
Dr. Naik, would you like to comment on that?
Sure. So it was, say the patient presentation again.
Prior ACS, 25% lesion, I think is what you had mentioned. But the patient would be if they were diabetic or had a previous silent or asymptomatic ACS event.
Yeah, I think that sounds like a great patient to put that in. So I would, as you know, 25, and that, like Dr. Kaplan said, not even for future intervention, just for future optimal medical therapy, right? So, you want to stabilize this 25% plaque. As we know, MIs happen from less than 50% lesions. So vulnerable plaque that we don't understand what a vulnerable plaque is, things like that. So I would certainly offer that to that patient.
I would too. I mean, that was my second case was presenting. It was a 30% stenosis of the right coronary artery, and a week later, the patient was having acute coronary syndrome. So I would definitely offer that technology.
Dr. Kaplan, there's a few questions, and this is for the group, but we'll start with Dr. Kaplan. How soon after the initial ACS event can the patient receive the device, STEMI or NSTEMI? So we'll
honestly, sure. Honestly, they can be implanted during the same hospitalization. If they're the high-risk patient and the ejection fraction is above 35%, I think there's a strong rationale for implanting it right then and there. That being said, a lot of patients have a hard time just coping with any acute illness, especially a heart attack, and may want to defer that discussion to the outpatient setting. So we've also had those discussions as outpatients. I think Dr. Naik's case also illustrates the evolution that we can have with patients, whereas an electrophysiologist, a lot of times I'll see patients who have come in with an ACS event, their EF is low, we'll prescribe a wearable external defibrillator for those patients, and then monitor them and then reevaluate at 6 weeks or 3 months after optimal guideline-directed medical therapy. And then if the EF is below 35%, they're most likely going to receive a defibrillator. But if it's above 35%, then we strongly advocate for them to receive a Guardian so that they can help safeguard against any future loss of heart muscle.
What would you do? What is the criteria for a very high-risk patient that has not had an ACS event?
In terms of patients who have not yet had an ACS event, I think that will become a very important clinical trial for the future, where this profile of patient can prophylactically receive one and then be followed over the long term to see the beneficial impact. And then the only other thing I'll throw out there and see if any of the other members of the group have any final remarks is that, oftentimes when I'm having discussions with patients about this, I may, or most of the time, actually am not seeing them after that first ACS event. They've had that event in the past, but oftentimes they've also come in with another intervention. They had a stress test that was abnormal, and then they got a stent put in, and then they're referred to me by one of my partners. And the point I make to the patient is, look, did you have the same symptoms before you had your abnormal stress test as you do when you had your heart attack? And the answer for the most part is usually no, they did not. And that's when I bring up the subject of silent ischemia or atypical symptoms or mixed symptoms, and how having this device in is going to provide them with that 24/7, 365 security, which they wouldn't have if they were only being subjected to annually or semi-annual even stress testing. So that's where I found a big benefit in terms of my discussion with the patients. So at this point, do any of the other panel members have anything that they wanted to bring up?
Just
Well,
just one more, the question about how do you convince patients? I don't necessarily have to convince them. I used that seatbelt technology before. It's if you want the Guardian, the name is very appropriate. Do you want for us with complex PCI, at least we know there's a high chance of having something again, as opposed to not having an ACS event before. And so, if you want to be protected from that, like a seatbelt, then this is a device for you. So oftentimes it doesn't take much more convincing than that.
Sure, that's great. Well, we appreciate all these excellent questions and the audience's participation. Tonight, we've delved into a wealth of valuable information that I'd like to recap briefly. Our journey began with an impactful patient testimonial, followed by an insightful overview of verdicts and the Guardian by the company's president and CEO. During my presentation, we explored the ALERTS trial and how the Guardian, primarily designed for acute ischemia detection, offers indispensable diagnostic insights for coronary patient management. Dr. Manubin shed light on the importance of screening in both inpatient and outpatient settings and identifying patients who could potentially benefit from the Guardian implantation and how he engages in the discussion with those patients. Dr. Knight presented a compelling case illustrating the Guardian's role in monitoring a cardiogenic shock patient at risk for severe cardiovascular complications post-myocardial infarction. Lastly, Erica Albritton provided valuable insights into the introduction to a health system and reimbursement process for Guardian implantation and long-term monitoring, emphasizing the benefits it offers healthcare systems and practices. The primary reason the Guardian matters: it provides peace of mind for cardiologists, patients, and their loved ones. It's no surprise that the FDA recognized this as breakthrough technology addressing an unmet need in its approval letter to the company. Just to review a few points about indications and contraindications for the Guardian. The indication, as you can see there, is for patients who have experienced an ACS event and remain at high risk for recurrent events. It is accurate and gets patients to the hospital faster. It's not suitable for those patients who already have existing implantable devices, conduction abnormalities such as bundle branch block, and an inability to recognize the alarm. Finally, I'd like to turn the session back over to Holly Windler. Thank you for everyone who attended today.
Thank you, Dr. Kaplan. Wow, thank you very much to our panel, and especially thank you to everyone who joined us here tonight. A special thank you to everyone else for all of your questions. What a great session that we had. The presentations were insightful and valuable and really have the potential to make a significant impact on patients at high risk of heart-related coronary artery disease. So guess what? Our journey doesn't end here. We do have an exciting series planned for December and beyond, with online summits focused on the history and future of Guardian technology, women in heart disease, and a patient summit about living with heart disease, and so much more. So stay tuned for more info on those. And if you were inspired, as we saw in the chat, for someone who would like to schedule a reimbursement overview, get a little bit more detailed on what that is, please go ahead and place a 1 and we'll follow up with you on that one. And lastly, we would just, on behalf of the whole team here, we would really like to sincerely express our gratitude for the time you invested with us today. Thank you, and we will see you next time.